we'll be playing the recording.
Sure, thank you. Good morning, friends. We will be starting our session with the common traps and how to avoid them. Traps are situations which are not very clear at first glance. Such situations do happen in our practice, and because echo is an imaging modality based on which surgical decisions are taken, it's important for us to understand how we could avoid them. I'll be sharing few cases where I have experienced traps in a similar way. This is a child, 1 year, 2 months old, operated tracheoesophageal fistula on day 5, saturating 80%, and had the diagnosis of tetralogy of Fallot. Had moderate tricuspid regurgitation, the cause of which wasn't very clear. This child was taken up for total correction. After the surgery inside the OT, he was found to have a posterior muscular VSD, which was additional. It was thought to be insignificant. However, in first 12 hours, he misbehaved. He had borderline pressures, urine output, and acidosis. His X-ray also looked plethoric, and hence decision was taken to go back in again. A 8 millimeter fenestrated muscular VSD was found close to the inlet area in the posterior muscular septum, and this was closed. And this VSD was completely different than the main VSD related to tetralogy of Fallot. In 24 hours, his hemodynamics improved and he was extubated in 48 hours. His tricuspid regurgitation also reduced. Additional VSD can be missed in tetralogy of Fallot because the RV and the LV pressures are equal. So this is a trap due to hemodynamics. On carefully going back and looking at the pre-op images, the upper posterior muscular septum was found to be unhealthy and having fenestrations. So the color flow may not cross, but still. It's important to see the entire muscular septum in all these views and do a complete sweep on 2D and color. In situations where RV pressures are equal to LV pressures, to rule out a VSD, or even in situations where pulmonary vascular resistance is high, like in newborn or in a fetus. In this child, retrospectively, then it was thought that the tricuspid regurgitation also could have been because of the lack of support in the inlet area. This is a 45 days old baby, saturating 65%, was distressed, and the X-ray was typical no cardiomegaly and pulmonary venous congestion. Expected to have a TAPVC, and that is what the confluence was seen behind the LA. And then where was it draining? So this confluence we can see here, the right-sided veins are entering the confluence, receiving the left-sided veins and having a descending vertical vein. The descending vertical vein means it was thought that it's an infracardiac TAPVC. On carefully following up this vertical vein, it was seen to take a turn, go to the right side, and then again ascend upwards and enter into the azygos. So this was a vertical vein which was descending and then ascending. Finally, the drainage was a supracardiac TAPVC. CT scan was considered because it was a rare sort of a drainage, and it confirmed the same insertion into the azygos. And hence, it's understood that descending vertical vein in a TAPVC does not always mean intracardiac drainage. So this is a trap due to conventional understanding. The common classification tells us if it's supracardiac, you need to have an ascending vertical vein. If it's infra, it is descending. But it's very important for us to trace the exact drainage of the venous confluence and also to delineate individual pulmonary veins. In this child, the benefit was in reducing the morbidity during surgery because the azygos vein drainage was picked up and it has important structures surrounding it. This is a child who was a 20 days old baby, tachycardic tachypneic, and had saturations of 85% in the right upper limb, 80% in the right lower limb. Had bounding pulses in the right upper limb and feeble in the left upper limb and lower limbs. The clinical diagnosis was definitely kept as a co-opt or an interruption with respect to PDA. And on echo, he was found to have a single great vessel, which was predominantly coming from the right ventricle. And it was actually giving rise to aorta and branch PAs. So obviously the thought was given that this is a truncus arteriosus with arch interruption. Now in the parasternal and the suprasternal views, this is the ascending aorta which was found, good sized. However, the orientation of the ascending aorta was a little odd. And the so-called trunk was actually finally terminating as branch pulmonary arteries and a restrictive PDA which was probably supporting the systemic circulation. So it was a little odd because the aorta was related to the pulmonary arteries in a different way. It was right and posterior, and also the left main coronary artery was seen coming from the ascending aorta, whereas the so-called single pulmonary valve was separate from the left main coronary artery. And hence it was understood that this was not a truncus, but it was an aortic atresia with an AP window. So in this situation, it was a little confusing because the aortic atresia had good-sized ascending aorta, and hence it was mimicking a truncus. So this was a trap which was related to the interpretation of these structures. So how we could have prevented it is, it's important to see the orientation of aorta in relationship to the branch pulmonary arteries when a truncus is considered, and also very important to establish the origin of the coronary arteries. Paradoxically, in this child, the management did not make a difference. This is a 9-year-old child who underwent a BT shunt at the age of 11 months, saturations of 65%, and had class 2 to 3 breathlessness on exertion. On echo, had L-looped ventricles, situs solitus, L-looped ventricles, and both the great vessels coming from the morphological right ventricle. Had mitral regurgitation, which was moderate, and right atrium was dilated. Now, for looking for the BT shunt, a detailed suprasternal view was done, but the BT shunt wasn't visualized. What was seen was the dilated SVC seemed to be having a connection with the branch of the arch of aorta, which was the right subclavian. The right subclavian artery seemed to be having a communication with the SVC. And this communication was seen in all the views on 2D and color. So a suspicion about systemic AV fistula was considered. So obviously the next thing was to do a cardiac CT. And the cardiac CT, surprisingly, did not show the AV fistula. The branches from the arch of aorta were completely different, separate from the SVC and the left innominate vein. So a systemic AV fistula was ruled out. Then what was it that was seen on echo? So this brings back to the basic understanding about principles of ultrasound, where a false positive defect can be seen when the beam of light is parallel to the area of interest. So this is a trap due to the physical principles of ultrasound, and it's important to consider the whole picture. In this child, probably the dilated SVC related to mitral regurgitation caused the flow reversal and the confusion. So it's important to use additional tools whenever possible, like clinical examination, Doppler study, etc. Now, this is a 9-year-old child who underwent a redo surgery for an RVOT. His initial surgery was for top absent pulmonary valve at the age of 1 year. And now the repair was done with a Graham-Nunn technique. Now, when we see these images, the first thought is that this child has free, unguarded, open pulmonary regurgitation. These are the images of after surgery. However, once we try to understand what sort of a valve is put, the Graham-Nunn valve is typically opening like this, and this valve was placed very close to the branch pulmonary arteries. So on careful evaluation, we can see that from the level of the valve leaflets, there are only 2 jets, which are very typical of Graham-Nunn, of mild pulmonary regurgitation. So sometimes the estimation of pulmonary regurgitation can be fallacious, and this is because of the uniqueness in the functioning of the valve. It's important to carefully look at the technique of the valve functioning, the position of the valve, and the degree of PR needs to be checked systematically. In this child, maybe 1 or 2 points were not valid because of the dilated branch pulmonary arteries. And it's important to see the pulmonary regurgitation in all the views. This is one situation which can misguide a lot. Coarctation in presence of a PDA will not give you gradients at the arch and will not give you Dopplers in the descending aorta suggestive of coarctation. In a similar way, we also have this is the arch which on 2D looks completely wide open, whereas when we put color, we realize that there is an extremely tight coarct, and the blue flow is only the trickle of flow which is happening distal to the coarct segment. And hence, it's important that we might be underestimating the coarctation in presence of PDA and LV dysfunction. It's very true to say that there is nothing as tricky as coarctation. Dopplering the descending aortic diaphragm is also an important way not to miss low thoracic and abdominal coarct. 2D clarity on the size of the arch is important to make sure we do not miss hypoplastic transverse arch. Color and spectral Doppler should be done before we say there is no coarctation. And hence, to summarize, it's important for us to understand that ultrasound machine does have limitations. There are cardiac hemodynamics which are very peculiar, which can create confusion in certain situations, and that our mind always thinks common lesions first. So because of these reasons, we end up missing certain cardiac lesions and also sometimes seeing certain things which do not exist. The list keeps going, like mitral regurgitation and aortic stenosis gradients could be overlapping, understanding a pericardial fold as a coronary and think that coronary is dilated, etc. So it's important that we put the whole picture together, do echo only after a basic clinical history and examination. Complete sweep is a must, and do not just have a target approach. It's important to put the hemodynamics with the structural information, and we need to understand that there are limitations related to physiology and the physics of ultrasound. Thank you very much.